Welcome to STEM Talk.
STEM Talk. STEM Talk. STEM Talk. STEM Talk. STEM Talk.
Welcome to STEM Talk, where we introduce you to fascinating people who passionately inhabit the scientific and technical frontiers of our society.
Hello, I'm your host for today's interview, Dr. Marcus Baumann. Joining me to introduce today's podcast is Dr. Ken Ford, IHMC's director and chair of the Double Secret Selection Committee that selects all the guests who appear on STEM Talk.
Hello, Marcus. Great to be here.
Today we have Dr. Brian Cole, an orthopedic sports medicine surgeon at Midwest Orthopedics and professor of orthopedics, anatomy, and cell biology at Rush University Medical Center in Chicago. Brian is managing partner of Midwest Orthopedics and the department's associate chair and section head of the Cartilage Research and Restoration Center. He's also the chairman of surgery at Rush Oak Park Hospital. Dr. Cole's research interests include cartilage restoration, orthobiologics, and minimally invasive surgical techniques for the treatment of the knee, elbow, and shoulder. He serves as the team physician for the NBA's Chicago Bulls, the co-team physician for the MLB team Chicago White Sox, and he's also the host of the Sports Medicine Weekly podcast.
In today's interview, we talked to Brian about his cutting-edge research into ways to treat knee, shoulder, and elbow injuries. Brian shares his novel approach to dealing with ACL tears, one of the most common sports injuries, and his investigations into enhancing the healing and recovery time following ACL reconstructions. He also discusses new advances in minimally invasive surgical techniques for many common injuries. In addition, we had an interesting conversation with Brian about exciting developments in the use of stem cell treatments, as well as the use of bone marrow aspirate to treat injuries. Before we get started with our interview with Brian, we have some housekeeping to take care of. First, we really appreciate all of you who have subscribed to STEM Talk, and we are especially appreciative of all the wonderful 5-star reviews.
As always, the Double Secret Selection Committee has been continually and carefully reviewing iTunes, Google, Stitcher, and other podcast apps for the wittiest and most lavishly praise-filled reviews to read on STEM Talk. If you hear your review read on STEM Talk, just contact us at stemtalk@ihmc.us to claim your official STEM Talk t-shirt.
Today, our winning review was posted by someone who goes by the moniker ECO8808. The review is titled, A Delightfully Eclectic Podcast. The review reads, STEM Talk is a wonderful podcast that I've been listening to for several years now. What continues to amaze me is the sheer volume of different subject matter experts interviewed on the show, and no matter the topic of discussion, Ken and Dawn always have insightful and knowledgeable questions, from human biology to psychology to AI to technology and engineering. STEM Talk seems unable to be pigeonholed into one niche. Having just graduated with my undergrad in psychology, I can say that I have very much benefited from STEM Talk. It has broadened my knowledge in a number of fields that I likely wouldn't have gotten exposed to otherwise. Ken and Dawn's emphasis on interdisciplinary research is a sentiment that I will take with me for the rest of my academic career, and it is all thanks to STEM Talk. Thank you for making scientific knowledge accessible.
Wow. Ken, I think we should send ECO8808 a couple of t-shirts for that review. At any rate, thank you, ECO8808, and thanks to all other STEM Talk listeners who have helped STEM Talk become such a great success.
Okay, and now on to today's interview with Dr. Brian Cole.
STEM Talk. STEM Talk. STEM Talk. STEM Talk. STEM Talk.
Hello, Brian. Thank you again for joining us today. I understand that when you were around the 8th grade, you fell in love with a popular sitcom, The Bob Newhart Show. I understand it had a big impact on you. How so?
You know, it's interesting. If you ask any individual who is currently in medicine or in the healthcare field, the vast majority would say, hey, the reason I chose this is because I love to help people. And, you know, as rudimentary as that sounds, it still is a preserved tenet across the board, despite how generations have changed and even, you know, sort of the current generation in terms of the things that they prioritize in terms of balance and so forth. But that's sort of one of the common tenets. And the Bob Newhart Show was one of those shows, those of you who are old enough to remember it, was the deal was that he liked to help people, but he did so with a sort of a sense of humor. And it was real life situations, but he was actually able to have an impact on individuals, not in a medical way, but it was psychology. It was more like sociology, and had a positive impact, but did so with this sort of overarching theme of having a sense of humor while doing so. And there was just something about that I found entertaining, but sort of had this hint of, hey, I'm actually making a difference in someone's life. And I've always had an interest in psychology and psychiatry and psychoanalytic theory and so forth. And it sort of overlapped with that as well.
I remember that show well. So after high school, you enrolled at the University of Illinois. When you set foot on campus, did you know you wanted to major in biology and psychology?
Even then, getting into medical school was a competitive situation, and I had an interest in psychology. And in fact, when I went to University of Illinois, I thought that going into the field of child psychiatry might be something that I would be interested in. So heading into orthopedics in the end of the game was clearly not something that I could see around the corner. But I knew that I wanted to do psychology and neuropsychology. And the reality is it's not nearly a competitive enough major. So I doubled major with biology, which was far more typical and a little less risk in terms of what goes on when you start to apply to medical school. So that was the primary reason I did a double major. I mean, you take enough biology that it isn't but a few more classes to actually have a double major in biology just because of the pre-medical requirements at that time.
You next traveled upstate to the University of Chicago, where you earned an MD and an MBA. As you mentioned earlier, you always knew you wanted to be a physician, but what led you to pursue an MBA as well?
One of the things that was common then is that when you knew you're going into medicine, it was a sort of a single track in terms of the kinds of classes you took. And I evolved away from psychology, psychiatry into the field of OBGYN and infertility. And I thought that might be an area of interest. I actually, the funny thing is in medical school, I liked almost everything I saw. I thought that infertility was really fascinating. And what I learned and what most people learn along the way is the value of role models. And in OBGYN, what was happening was at the exact same time that HMOs health maintenance organizations were coming on the scene, primarily on the West Coast. And there was an egress of physicians leaving medicine at the time because of the threats of managed care, the threats of loss of control, the threat to the independent practice, which was very real in the 1990s. And I had not had a single business class since I was basically in the 6th grade. I took no business classes whatsoever. And I think that besides the desire to go in to help people when people choose medicine, the other concept is a sense of independence. And, you enter on this, in this tunnel of, in fact, I was speaking the other day to one of my daughter's friends about how many years after college it took to become an independent orthopedic surgeon. And it was 13 years by the time I actually finished college and had an independent job that I have today, actually. And the threat to one's independence was something that was really, and the loss of control was something that I placed a premium on at the time. And I felt if I didn't have anything but a medical education, that I was be in a position where I may not have enough insight, the ability to maintain independence and control. And getting an MBA at that time was a very unique thing. It's interesting now; it's actually quite common, but at that time it was very unique. And University of Chicago offered a joint program for health administration. And I was already a student. So I felt like, look, if I'm ever going to do something like this, now is the time. Because going back to school once I was in practice, I thought would be very difficult given the direction I thought I was going. So in light of that, doing the MBA was something that came up about my second year of medical school. It was an opportunity the University of Chicago put forth. Only one person had ever done it before. And now it might be up to 20% of some medical school classes, people do a joint degree. It could be JD or MBA. It's much more common, but then it was very, very rare, but has served me very well in sort of my current endeavors, and it really afforded opportunities that I didn't think I would otherwise get. And I think it did it accomplished the goal of being sort of at least some level of competency and a vocabulary that helped me maintain the independence as a physician today.
Yes, you were perhaps prescient in before your time in your concern about loss of independence, and that's pretty much all you hear these days talking to physician friends is the inability to function as sort of an independent physician. It's increasingly difficult for them.
Yeah, it is. And it's, when people ask, well, what's the current sort of threat to the happiness factor as it relates to being in medicine? It is largely the loss of independence. What you see now as students go through medical school, it's becoming a new norm to say, hey, I'm going to just be done and work for a hospital system. In orthopedics, it was about 25 to 30% were employed by hospital systems. Now it's tipped over the midline of 50%, and I've heard numbers as high as 70%. So, like anything else, there's trends that happen over time. So I think it's becoming increasingly common where someone is really in an employed situation. Doesn't mean you don't run the flavor of your practice. You don't have the ability to be the kind of physician you wish to be, but it has clearly changed. And like any other occupation. Being in medicine is a business as much as a craft and art where people have passion to practice. There's the objective side of it is you have to pay attention to what it takes to actually run a business in order to be able to then take care of people.
Your next move was to New York City for an orthopedic research fellowship in metabolic bone disease at the Hospital for Special Surgery. That place has a long and distinguished history. You did your residency there also. So how did your relationship with that facility come to pass? What was the connection?
So it's, as I mentioned, it's a long road to get from college to where one sits today as an independent orthopedic surgeon in an academic setting. And the Hospital for Special Surgery used to be known as the Hospital for Ruptured and Crippled Children. It has probably the most historic presence in the academic orthopedic space in the world in New York. And I completed a year of general surgery in Chicago at Loyola, and then transferred to the Hospital for Special Surgery. And, when I went to medical school, I actually applied to an MD MSTP program, which is the MD PhD program, because I knew I wanted to do research. And one of the great things about orthopedics is you don't really have to have a PhD or even a master's degree to do research. It's, we've been very successful in maintaining relevance in the sort of peer-reviewed space and on the podium in a center as long as the infrastructure is there. But I really thought that it would benefit me to have at least a year of research, which is what I did. I stepped out after a year of general surgery to do a year of research at the Hospital for Special Surgery in metabolic bone, osteoporosis, and cartilage work. And that's actually served as a framework for the rest of my entire career. Over the last 25 years, I've spent, a significant amount of time, in addition to seeing patients and doing surgery and managing professional teams and so forth, is actually doing research. And that actually taught me the tools to do so that added on to what I learned when I was an undergraduate at the University of Illinois.
Yeah, that's really great. We actually are developing some collaborations with HSS now here at IHMC. So after your research fellowship there and residency as well, you went to the University of Pittsburgh for a sports medicine fellowship. What led you there, and what drove your interest in sports medicine?
Yeah, I guess you're never done learning. We're always a student. And after residency, I knew I wanted to specialize in sports medicine. And the University of Pittsburgh was the top sports medicine fellowship. And at that time, I think HSS was the top residency. And I was, very lucky to get an HSS. One of the things that was interesting, I applied to 2 residencies from the University of Chicago, OB-GYN and orthopedics, not knowing exactly what I wanted to do. And I finally made a decision. And I wasn't sure I'd get a good residency spot, but I was, because my reviews were good, I had done research and had a sort of an interesting different path. I had a fair number of options and opportunities in residency. And that carried forward just based upon, my pedigree and the things that I was doing at the time to the University of Pittsburgh. And that time, that was probably the best sports medicine fellowship. And I trained with some real greats, one of whom is still in practice. J.P. Warner is at Harvard, who's a wonderful person, but also an amazing shoulder surgeon, great thinker. And Freddie Fu, who passed last year, who was a world leader in sports medicine, was just an absolute legend and visionary in sports medicine and was one of my major mentors in my life. And then Chris Harner. So it was a really very, very good fellowship at the time to do 1 year of specialized training before I, too, went into sports medicine here at Rush University Medical Center here in Chicago. So yeah, it's 1 year of specialized training and just doing basically shoulder, elbow, knee, learning how to manage athletes and so forth, and took care of the University of Pittsburgh football team, and had the opportunity to really hone in on my craft and provide the opportunity for specialization when I was done.
So going back to residency, when you were a 4th-year resident, I understand you got an interesting phone call from someone back home in Chicago that turned out to be quite fortuitous. Can you tell us about that?
One thinks that when you're going through residency, then you don't really know what's ahead of you in terms of actually landing a job. And being from Chicago, certainly it was of interest to work in Chicago, but I wanted to look elsewhere and had just gotten married and wasn't sure where we wanted to settle. And Dr. Bernie Bach, who founded the sports medicine division at Midwest Orthopedics, now called at Rush, otherwise Rush Orthopedics or Rush University Medical Center, and he also had a sports medicine fellowship that I interviewed at, but did not wish to train there, knowing that I might end up in Chicago. So he called me when I was operating, and he was also a legend, also one of my most amazing mentors, and said, "Look, when you're done, if you're not going to train here, would you be interested in practicing here? I'd rather have you as part of our group than one of our competitors if you come back to Chicago." And while I did tool around a little bit, looking at other job opportunities, this was an amazing opportunity for me, and it's where I still stay. 50 to 75% of people move jobs in orthopedics after the first 1 or 2 years, and it's never even been a consideration since I started nearly 25 years ago. So having a job, getting that pressure off my plate, and finishing my 5th-year residency and then doing a fellowship without having to worry about where I was going to be employed was a pretty amazing privilege at the time.
Midwest Orthopedics is one of the nation's most respected private orthopedic practices. And through a partnership with Rush University Medical Center, Midwest has developed just an amazing reputation as a leader in sports medicine, hip, knee, spine, and cartilage restoration, as well as shoulder care and pain management. For listeners who aren't familiar with Rush, it is an academic medical center that includes a 671-bed hospital. Rush is a center for basic and clinical research with physicians and scientists engaged in literally hundreds of research projects. Brian, can you talk a little bit about the scope and the nature of the work that goes on at Rush and Midwest Orthopedics?
As you mentioned, we're essentially a private, independent orthopedic practice. We're one of the largest practices now in the country. That being said, we have a direct nexus to Rush University Medical Center, which has a medical school, a school of nursing, has a robust multidisciplinary research program. It manages all the continuing education, so-called ACGME requirements to actually train residents and fellows of the next generation of students. And it allows, I think, everyone to sort of emphasize their strengths and really survive at a time where healthcare has just an enormous number of economic and macroeconomic pressures. This allows each of us to sort of, while we stay in our lane, we have the opportunity to have a symbiotic relationship, which I think, frankly, is in some ways the envy of the country. I would argue, just because we are able to do things collaboratively. But we don't always have the same mission. We're a single specialty, whereas a hospital has a focus on making sure they serve the community, overall excellence in teaching and nursing and educating our next generation. And we essentially having the opportunity to help manage and oversee the academic pursuit, everything from research and philanthropy and development, as well as I mentioned, sort of integrating and teaching our next generation, and then providing the research infrastructure is pretty unprecedented. So it is a model for, in my mind, a model for success to help everyone thrive, both, in the ability to sort of emphasize the best outcomes and take care of patients. But also, as mentioned, there's an enormous number of resources that are required to do research that you have to have an institution behind you. And then the other area that it really has proved to be profoundly beneficial is we manage a number of professional sports teams. And in that management, it isn't just an orthopedic surgeon or a primary care sports medicine person. You need a hospital behind you because the team, the organization, the front office, they have other problems that are in addition to musculoskeletal issues. So you have to have a hospital behind you to help get it done well. So it's proven to be, I think, the best model to date, certainly not without challenges. But when those challenges occur, as they happen in any setting, we have the sort of the depth, the infrastructure, the bench to manage it pretty well to keep things moving forward.
Yeah, let's touch on that connection with pro sports. You're also the head team physician for the Chicago Bulls and the co-team physician for the White Sox. I imagine these are quite interesting positions. Can you share with us the nature of the work and some of your more interesting experiences?
Being in sports medicine provides the opportunity to take care of a whole range of individuals. And while professional athletes are absolutely, a core part of what we do, I would say that just managing active people who have the same types of injuries, who wish to remain active and with less pain is, the mainstay of our practice. But managing professional sports teams is a privilege, but it comes with a whole mixture of challenges, both politically and legally, and how we manage patients in the professional sports setting is a bit different sometimes than the way we do it in the recreational athlete setting because of all the forces that are involved, and the stakeholders are far more broad, and it's almost like a hub and spoke model. But I would tell you that that's been, one of the greatest privileges is being involved in managing athletes from a variety of sports, whether it's professional soccer, basketball, baseball, hockey, and also, managing individuals at the collegiate level. It's been, I've been the head team physician for the Chicago Bulls for 18 or 19 years now. And being involved with the NBA and helping to contribute to the health and wellness even from a population point of view, as well as just helping and assisting and, managing our own athletes has probably been one of the most satisfying things that I do. It is profoundly time consuming. I used to cover a lot more baseball, but it's very difficult to do baseball and basketball. So I, serve as co-team physician for baseball for the White Sox, and we've done the Chicago Dogs, which is an independent baseball team, for a number of years. But my main focus has been with the Chicago Bulls, and it really is tough to manage more than one team as a primary decision maker and lead, and actually, do the job that needs to be done. But as I mentioned, it's pretty time consuming. But the best part about it is it's provided a sense of balance, having the opportunity to get to know athletes, at a interpersonal level, but yet keeping it at sort of arm's length so you can always maintain your efficacy and trust has been one of the most enjoyable aspects of my career. And also sort of pairing out the differences between different athletes in terms of their personalities and how they handle injury and pain and so forth. It's so different. If you look at a female professional soccer player and compare that to a professional basketball player or a baseball pitcher, there are, just enormous differences in the system and how they may manage actually the same injury. So because of the demands on them and, everything from how contracts are managed to, traditional stereotypes and personalities, and being adaptive and nimble and open-minded and trust and building trust and confidence is a whole other side of just what I do day to day. But it's proven to be, still to this day, after 25 years of doing this, been one of the most satisfying aspects of my career.
I'd imagine that's very challenging given the overlap amongst seasons, baseball and basketball in particular. So in addition to seeing professional athletes, you have a wide range of patients who also come to you with injuries and pain. Many of them are non-athletes. Some of them are children. Some of them are senior citizens. Over the years, you've performed over 20,000 surgeries. Can you give us a sense of the patients you see in sort of broad strokes and what it is that you do day in and day out?
I can easily reflect back, as I indicated, to say, look, many choose to go into healthcare and medicine because they want to make a difference for people. And the surgical side is just one part of what we do as orthopedic surgeons. I would say that it is really the interpersonal side that remains, equally or sometimes more satisfying. My life is basically 2 days of patients a week and 2 days of surgery a week, and then 5 days of administrative oversight, research, managing teams and everything else. So it's a number of jobs folded into one. But, the crux of my clinical work is still having the privilege to see patients, to sit down and get to know a number of people on a given day. Some people find clinic to be very challenging and probably more difficult than anything else that we do, because when you think about it, those who have a problem are often very anxious about the problem. They're worried that they're never going to get better. They're never going to be out of pain, be able to function. And while it may not be life and death in orthopedics, they have a very specific issue that they're often desperate to resolve. And that still has remained one of the most satisfying aspects of what I do, is actually having the privilege of taking care of people, sitting down and solving a problem and getting inside the head of someone in sometimes less than 5 minutes and understanding what they need and how to make a difference in their life is, I would say, one of the greatest privileges. And as I was reflecting recently with talking to a young person who I mentor and saying, look, there isn't a day that I go to the office that I'm unhappy going into work. And the surgery is sort of the easy part. We may be up to actually 25,000 surgeries over 25 years or more, but it's not about the volume. It's about having the privilege to make and knowing that people have trust and confidence that you're going to make the best decision consensually, but ultimately in their best interest, and providing reassurance and confidence that, hey, this is a bad time, this is a hiccup, but it's going to be behind you in all likelihood with a successful outcome. And I've branched off into a super specialty in cartilage replacement and cartilage repair, which is rather unique. The bread and butter is just taking care of people, everyday people like you and me, who say, look, I just would like to have less pain and more function, and sitting down and saying, let me first make sure I understand exactly what you're looking for and explain to you that, well, if you need treatment, your symptoms have risen to a level that you really want help. Let's talk about what the options are, and they're either non-surgical or surgical, and let's walk through the list of non-surgical options and what the expectation is. And should that fail, this might or could be a surgical situation. And what does it take to undergo surgery, and what's the recovery like, and what should you expect in the end of the day when this is behind you in terms of the level of pain relief and the restoration of function. And that's while it may sound onerous to the person on the outside, it's a day in and day out episode in what we do with people, and it still is proved to be sort of really the most satisfying, fulfilling aspect of what I see and do. And I think, when, despite all the challenges in healthcare and despite the fears that young people have when they're coming out into medicine, they should look at the other side of this and say, look, if that's what it delivers, then this is all going to be worth it. And I can tell you, if they're provided the right opportunity, it still is just that. And maybe I'm lucky and have been, I don't want to tempt it, but I've been spared some of the real challenges that make it profoundly dissatisfying for individuals to practice medicine. I was saying, at the end of the day, having the privilege to see people and take care of them never gets old, and is, clearly I would say a real privilege.
One of the topics you often talk about is the concept of treating the patient and not just the X-ray or the MRI. This was actually certainly my experience when I visited you, by the way. Most people who suffer pain, they get x-rays and MRIs, and then suddenly both the patient and the physician are often really focused on that. All of this information often leads to two concepts that you refer to as, rather amazingly, as barf and vomit. So what in the world is barf and vomit? What are these concepts about?
Okay, so I get it. It sounds gross, but I think backing up before I tell you about that, and I didn't coin that. That was published in I believe in the British Journal of Orthopedics. Way back when one of my mentors was an individual that I had the opportunity to rotate with, Dr. Mendelsohn, who was a pediatrician who was clearly atypical. He wrote a book called The Medical Heretic, and I would say that he was a heretic at the time, and as a pediatrician, and not globally accepted within his community. But there was this concept of technology over reason that he really considered when evaluating patients, and he felt that there was just an enormous amount of sort of medical paternalism in our world, and there was inequities between treating men and women and the access to healthcare and the decisions that were made, and that often we would just over-test because patients were expected to be tested, and yet we, using the results of those tests and how we made decisions, was often disconnected. And this concept of technology over reason has led to this prevailing tenet in my career of sort of doing less, not more, but explaining to patients that we can make a diagnosis by doing the things that we learned in medical school, which is, oh, by the way, just taking a history, understanding the natural history of disease, what's likely to happen in various age groups. I mean, you can walk in a room in 10 seconds. It's not like a judge who's made a predetermination or the jury's made a predetermination. In about 10 seconds, I can put things together and largely know what the problem is. When you do things over and over again, the space starts to feel smaller and smaller. And every once in a while, you could be fooled or there could be a zebra. But, truth be told, most things fall into that bell curve with only about 2.5% sitting outside on either edge, and everything else falls in the middle, which is something that's more common. And using tests should be an adjunct to care, not to replace taking a history, doing a physical exam. Whatever objective tests such as radiographs need to be done, you can make a determination. There isn't anyone I know who's ever taken an MRI and said that they feel better after taking the MRI, right? It's not therapeutic, but from a psychological perspective, patients have this need that if I don't get an MRI, then we're less of a physician. I remember a story way back when I first came into practice, and then a young woman came in and says, look, I was running down the field and I turned directions and I felt a pop and I felt my knee give way and it swelled up and I had trouble standing. I couldn't keep playing. And she walks in and she can't fully straighten it. And I said, you have an ACL tear, a medial collateral ligament sprain, and you might have a meniscal tear. And if you wish to continue to play sports, there's a probability that your knee will continue to give way. And the right thing to do is let's get your knee restored here in prehab. And then we'll talk about doing an ACL reconstruction based upon your physical exam and your story. I'm confident that's what you have. And I was 99.9% confident and correct. Yet the next week, and they said, well, can I get an MRI? And I said, you can get an MRI, but it's not going to contribute to my decision making. And this is what you have. But if it, so I think, it's probably, a waste of your time, and financially it's probably not, it really isn't worth the economic impact. So, let's make an intelligent decision here. And I know I'm right. The next week, the patient was on my partner's schedule, Bernie Bach, who's recently retired, who I told you about before, who's my mentor, who brought me into Midwest Orthopedics at Rush. And she left my practice because I didn't order an MRI. No matter what I said, I couldn't convince her that the MRI was not important in the decision making. And somehow people feel that the MRI is critical to making them better, when it really is a diagnostic tool that might have some prognostic ability in some instances, but not all. So this concept of barf and vomit, barf is the brainless application of radiologic findings, and vomit is being a victim of modern imaging technology.
Oh, I love it.
And, I had a patient yesterday who is a MMA fighter who came in. He had a previous ACL reconstruction. He came in with his MRI, and he says, I got kicked in the knee. He got an MRI, and he has meniscus tears on the inside and the outside. He has cartilage loose bodies there. His ACL that he had reconstruction doesn't look good. He had a swollen knee and some arthritis. And he was there feeling better after he got kicked in the knee, 3 weeks earlier, saying, look, I've got all this stuff. I'm really worried, and I was told I need surgery. And everything on that MRI was present the day before he got kicked in his knee. You and I, there's this phrase that Atul Gawande, who's a surgeon in the Harvard system, who's written a number of books, says we're all sort of rotting from the inside out. And my opinion, we are sort of all rotting from the inside out. Our tissues don't, every day things start to deteriorate and we accumulate these findings. But applying the findings on an MRI or even an X-ray, there's just this enormous disconnect with what studies show and how people feel. And if we relied and treated MRIs and X-rays, we would often make very different decisions than we would by actually taking the human position into consideration, which is what happens when you talk to a person and ask them what happened and ask them what makes the symptoms worse, what makes it better, what are your goals, what would you like to see happen? Like that's the 5-minute to 8-minute interaction that makes all the decision-making possible. It's not often the MRI or the X-ray. So it's really, I find most of my time is spent, unfortunately, diffusing anxiety and in the best interest of the patient, providing reassurance. And it often pivots from what they are reading on their MRI report. So that's often the beginning. So it's a lot of that relates to actually what's great about medicine is things fall into these buckets, not always, but the vast majority of the time. And we can do things with less, not more.
Unfortunately, you're somewhat unusual in that aspect. I think the MRI is so captivating. People study the MRI and then they, this doesn't look good. And you say, but I can do pull-ups, I can do push-ups. And, it doesn't look good. So I think 18 years ago, I was told both shoulders needed to be immediately replaced.
Immediately, because if you didn't, God knows what would happen, right?
Yeah, that was 18 years ago. Right? Now, the day may come, right? But
That's right.
18 years ago was a long time ago.
Well, I mean, I think you have to help people understand that it's okay to coexist with what you have, and the decision later on will be no different than the decision today to make you well. And by not treating today, it is not going to put you in a worse place later on. And I think there's that prevailing concern that good pain and bad pain, and if I ignore it, I will be offered a different solution that may not remedy the problem later. So we might as well take care of this problem today, even though it isn't actually causing disability or pain.
Yes, in fact, I was told exactly that.
Yeah, and I think that doesn't always happen. And that is the core tenet to understanding why a person makes an appointment, waits sometimes 6, 8, 12 weeks to get to see a physician, drives to the clinic an hour, sits in the reception or waiting area for another hour, sometimes longer, and has a 5-minute visit with a physician. And they never got to the core root of saying, why are you here? What would you like to see happen? And what are your concerns? And that's actually a really efficient process. But if a physician doesn't do that, they never really get under the hood to say, why are you really here? What are your concerns? And our job is to actually understand the natural history of disease and what skillful neglect will deliver. And if you understand the literature and you have enough experience, you can actually help a patient with doing almost nothing but providing education. And that's really been the crux of my forward-facing tenet, which is, educate people, and which is why I started this a podcast of our own and writing textbooks and writing books in general and articles and really trying to help people understand what's important, what's not important. And it's amazing how you can have a population impact if you help people understand these basic principles.
So let's talk about torn cartilage in the knee. You just talked about a case of torn menisci and resulting in loose bodies in the knee joint. Back in your days as a resident, about the only way to help people with this was to surgically go in and clean out the knee, essentially just clean up the debris. With bone-on-bone pain making it so difficult to walk, get up and down out of a chair, climb stairs, and so forth, cleaning out the debris sometimes just led to people having to deal with and learn to adapt as opposed to really being better. Can you give us a sense of the range of options available today?
So, it's a complex process to manage patients with arthritis or any form of arthritis. And one area of subspecialization has been managing people with limited cartilage loss, such as local cartilage defects or losing their meniscus, and not broad arthritis. But when I was a resident in 1996, we only had the ability to put a camera in someone's knee and use a shaver to clean out debris and hope that they got better. And there are, I treat 11, 12, 13-year-olds with early arthritis. And that doesn't do well for someone who has that timeline, who's trying to live an active life, to stay healthy, to stave off all the other problems and the impact on self-esteem, for example, for a young person when they can't participate in their sports, and the probability of them actually going to college and having, a societal impact is often dependent upon their ability to be active and pain-free. But we didn't have solutions back then for people with localized arthritis, right? We just didn't exist. So there's been this evolution over time of both non-surgical and surgical treatment that actually can make an enormous difference in someone who has pain related to arthritis. Not everyone who has arthritis or bone-on-bone changes on x-ray actually has pain, but those who do in any form now have a litany of options which are non-surgical, what we call orthobiologics, which frankly could be something as simple as a corticosteroid injection, evolving all the way through symptom-modifying treatments, not necessarily regenerative today in the office. I mean, that's something that we have our eyes on, but nothing today that we do in the office is truly regenerative in nature. So I like the word orthobiologics as symptom modifying. But we also now have surgical procedures, dating back to 1997, where we could actually move cartilage from one part of a joint to another, almost like a hair transplant, where you take healthy hair follicles and move it to another part of someone's head where they don't have healthy follicles. We can do that in the knee or other joints. We have techniques now that can take a small sample of cartilage and grow it in a laboratory and resurface joints. We can use donor tissue, particulate tissue from a donor or grafts from a donor of bone and cartilage and meniscus and do a transplant. And we do this even in professional athletes. We can take the patient's own cartilage and mince it up and put it into a defect and actually almost like seeds, grass seed, rather than putting a whole piece of sod, you put the seeds there and can grow new cartilage. We can do things today that we just didn't have available when I was a resident, and all we could really do is pat someone on the back and say, hey, listen, we cleaned out the joint. You gotta basically suck it up till you're age appropriate, and then we can maybe do a knee replacement. At that time, hoping that you won't need one or two more. And they live a life of pain and dysfunction until they're age appropriate for a replacement. So it was crazy the limited ability that we had back then compared to what we have today. And this area of cartilage repair, cartilage restoration, and the use of non-surgical techniques is totally different today than what I had available when I was a resident training. I mean, it looks like an entirely different field. So we help a lot of people now that we couldn't help then. And we can do it in many instances by just understanding, again, the basic tenets, the natural history of disease, and even applying those things that are symptom modifying, not necessarily disease modifying, can actually make an enormous difference as people sort of walk through the years of their adult lives to minimize the symptoms they have from their underlying conditions.
In the past couple decades, there have been numerous advancements in how to treat patients with shoulder, elbow, and knee injuries via non-surgical means. The scope of these non-surgical methods range from biochemical to pharmacological to diet to rehabilitation. Can you give us an overview of these non-surgical methods and the status of evidence supporting each one? Just a quick overview on this.
Yeah, so that would be a long lecture and much probably longer than your listeners would enjoy hearing at this stage of the game. For starters, I would just say that if people want to dive deeper, I believe our website is, essentially replete with peer-reviewed information that I believe you can trust. And it's not only generated from our institution, but from others that are highly published and credible in the musculoskeletal space. So it's briancolemd.com. But, I'll just, as a high-level overview, we have a number of symptom-modifying entities such as platelet-rich plasma, where we draw blood from an individual. We spin it down in a centrifuge to get a concentration of platelets, which produce growth factors, and those growth factors can actually inhibit inflammation and in some instances promote healing for tendinitis, say patella tendinitis, or reduce the symptoms of bursitis or inflammation. We have other disease-modifying agents that people try, such as bone marrow aspirate, which is, some people call it a stem cell therapy, but it really doesn't rely on the cellular population in the way that people imagine. We don't do things in the office where we inject stem cells and regrow cartilage. Unfortunately, we don't have that capacity, but we don't necessarily need to have that capacity. These things can be done to reduce symptoms and make people feel better so they can be more active. So using bone marrow, using fat as a source of components that produce growth factors that inhibit inflammation could be particularly effective. We have components such as hyaluronic acid, which is, some people call it a lubricant, but it really is an opportunity to sort of reset the biochemistry of the joint to reduce pain, maybe inflammation, and so forth. So we can trick our bodies into feeling better without stomping out disease using these non-surgical methods. And then there's surgery, and surgery can range from simple things to just going in and cleaning out a joint and making a difference in terms of how people feel, to restoring damaged cartilage with doing simple things like poking holes in the bone and adding bits and pieces of the patient's own cartilage taken from a healthy part to resurface that area, and supplementing that with bone marrow aspirate that's been spun down and concentrated, or maybe taking local fat to do the same thing to stimulate or upregulate the environment's healing response. We've learned that we can reduce re-tear rates and rotator cuff pathology by adding bone marrow aspirate, and at 1 year their MRIs look better than those patients who didn't have it. We've learned that taking bone marrow concentration and applying it to a tissue that's a cartilage graft and putting it in someone's joint can look healthier at 6 months and 1 year by CT scan when we use bone marrow concentrate to supplement the healing response. We have meniscus transplants where people who have missing their meniscus who go on to develop post-meniscus pain after they remove it. We can use donor meniscus to replace the missing tissue to restore function and reduce pain. People have to understand, though, that our ability to repair and replace cartilage is not necessarily for those who have bone-on-bone change. We are still challenged by this middle zone, the so-called unmet need, where people have exposed bone-on-bone change, they have deformity, they have bony changes. Our ability to render those patients less symptomatic with these sort of less invasive or less involved non-metal, non-plastic solutions is still particularly challenging, and that's the big white space that we have. And unfortunately, that's probably the highest density or incidence of patients falls into that category. But we can do things now that we couldn't do 25 years ago that can keep people functioning for decades before they ultimately might or could need metal and plastic placed in their joint.
Weight loss is certainly one approach to improving knee issues for many people, essentially just by reducing load-bearing pain. Could you talk a little bit about this, and how do you manage this with the patient?
From a high level, the way to think about it, I think, is that we can do one of two things when we have pain and dysfunction. We can shrink our world so that we have less physical demand so that we feel okay. Or you can expand the joint or problematic area's ability to meet the demands of the world without shrinking the world of activities that we engage in. And load is one of the quintessential tenets of why people feel badly. So think about it. You're a person who has shoulder pain. You can use you as an example. And let's assume that you used to play tennis or paddle or racquetball. And now you just give up all those activities and you generally do fine. So you shrunk your world by reducing the load on your joint. The lower extremity is also very load dependent, the hip, the knees, the ankles. What body weight does is it is an external source of load. So you could argue that muscle weakness, you can't tolerate load well. Body weight, every pound you and I carry above our knee is magnified, depending on your activity, 5 to 7 times. That might or could be something that's in our control. It's a way to reduce the external activity, but just losing weight. Excess body weight has another important contribution to symptoms. It's inflammation. There have been a number of basic science animal studies that have looked at the biochemical impact of having excess adiposity or fat. Not only is it a cardiovascular risk when you have excess fat around your visceral organs, right? Sort of the skinny fat concept, as it's been called, where you may not look like you have excess BMI, but you actually have a large amount of visceral fat that contributes to cardiac risk. Similarly, it has a biochemical impact on inflammation. So it's not just the pound, the force that it puts across our joints, which is clearly relevant, but it's also the biochemical impact. So that's one of our vital signs is our body weight and the impact that it places on our lower extremities. And I will tell you, as a physician, it is an important area that you have to feel comfortable to talk about, because if not, we're not really addressing the entire patient. And they don't really, they appreciate it. There's many instances where patients say, look, no one's ever told me that before. Obviously, it might have a health impact, but no one's ever told me that this has an impact on how I feel today. And I've had a number of patients who we've made feel better by just lifestyle modification and never giving them an injection, never doing surgery on them, and just having a conversation. So it is an enormous part of the holistic approach in managing patients. And it's so far beyond saying, hey, I just tore my rotator cuff, or I dislocated my shoulder, or I tore my omocollateral ligament in my elbow, or I have a meniscal tear. I mean, understanding that, if you really want to have an impact on people and population health, you have to have an understanding of all of those aspects. That's being a doctor. That's being an individual who can have an impact positively on another human being.
STEM Talk is an educational service of the Florida Institute for Human and Machine Cognition, a not-for-profit research organization investigating a broad range of topics aimed at understanding and extending human cognition, locomotion, health span, resilience, and performance.
So you've talked a lot about exhausting non-surgical options with patients, which I think many people appreciate. But there are some injuries that do require surgery, particularly for athletes, like an ACL tear. We see these all the time on sports pages and websites. There's always an athlete tearing an ACL. They're so common among athletes as well as workers in physically demanding jobs. There's about 500,000 ACL tears each year, according to the data. Can you give listeners a sense of what happens when someone like an NBA player, for example, experiences an ACL injury?
The ACL it remains sort of a relative epidemic in my space. Any given week, I will see almost 12 months a year between 5 and 8 people with an acute ACL tear. And they're typically in the age range of 14 to 25. Although you see it in older people. I've had people as old as in their late 70s or 80s that have functional instability after sustaining an ACL tear. So what's interesting about the ACL is that some people can be copers if they have a random event and they don't engage in ACL-dependent activities. Not everyone has to have an ACL reconstruction. Most people, however, tear it in an ACL-dependent sport so that when they no longer have an ACL, when they engage in that same sport, they have a sense of instability, which the ACL previously provided stability. So that's why they get reconstructed, because they, again, want to engage in a high-demand ACL-dependent activity. But there's other intangibles, such as preservation of the cartilage. The more instability someone has, the more meniscal tears they have, and potentially changes the natural history of their knee. Unfortunately, the injury itself changes the natural history of the knee and can lead to an incidence of the development of arthritis downstream. But all that being said, I think this is an area where we do generally a good job in restoring stability. The challenge is that I see patients 5, 10, 15 years down the road after they've had their ACL reconstruction done, and they've developed secondary changes like osteoarthritis and so forth. And I think that's the real problem, is that the impact of the injury itself, the treatment of it does in fact lead to a restoration of function. The natural history of their knee has changed in a sort of often catastrophic way that has to be managed. In general, though, we do a good job in the ACL space. We're doing a great job in getting people back to sport. And the failure rates have, gotten less than 5% with most graft decision making. And the return to sport in terms of reclaiming their pre-ACL function has become relatively predictable and happens in virtually every high-level sport. But, it's not without problems. It's not without variability. But it's an area that we continue to actively engage in research. We try to change the downstream natural history of the problems that occur after ACL injury and reconstruction. And I'd say most importantly, we're doing a better job in ACL prevention as we understand the biomechanical things that have led to this problem of, for example, women 5 to 7 times compared to men. If I'm in an office on a Monday and I see 6 ACL tears, 4 of them will be in girls and 2 of them will be in boys. So, or young women, young men. That would be a typical day. So there's an exponential difference in the frequency in women versus men.
Today, a lot of young people are tearing their ACL, and according to the American Academy of Pediatrics, ACL tears have sort of skyrocketed among 14 to 18-year-olds, up 148% over the last 10 years. What are your thoughts about this?
Well, it gets into the whole other discussion about specialization, super specialization in sports and the multi-sport athlete. And there are just so many more opportunities for young kids to engage early. And I think that's the biggest issue, is that they're starting early. It's the reason we saw the explosion of baseball injuries and elbow injuries and skeletally immature youth, because they can play baseball 12 months a year. There's no such thing as rest anymore, where we take 2 months off from the sport. Our best athletes today still are those who are multi-sport athletes. Those who, you look at the all-stars in basketball and in baseball, and these are people who, when they were young, they actually played more than one sport. And I think that's something that we are starting to feel more comfortable in terms of educating parents today, weighed against the imbalance of, hey, if they just take their time on this one sport, they're going to be an athlete and they're going to be the next NFL superhero. So that's the challenge with our young people. It's not just the kids. It's the interplay of the youth population with their parents. And I think, that's a whole other topic of discussion that is fascinating. And I, my best office visits are when I have a young person with the parents in the office and trying to balance. It's no different than a professional athlete who has an agent, who has a GM, who has teammates, who has their family, who has all the people whispering in their ear. It's a different dynamic, but the same type of complexity is when you have a young patient who comes in with their parents in the office and who just sustained an ACL tear or a Tommy John problem and walking through it. They have so much opportunity now to get injured, and the strength that they come with at earlier ages, they're just bigger, faster, stronger. People say, how would Michael Jordan perform today in basketball compared to today's population? It would be different. Arguably, he may be a completely different athlete today, integrating with his teammates compared to what he was years ago, just because the sport has changed so incredibly. So I think that it's the sheer volume of opportunities that are available for young people to do something 12 months a year, weighed against the fact that they're bigger, stronger, more skilled, have more exposure hours, that is leading to this epidemic of young people walking in my office with injury.
All of this has led to a critical need to develop novel strategies to enhance ACL healing and really to accelerate recovery time after anterior cruciate ligament reconstruction. You had a study designed to assess the effect of bone marrow aspirate concentrate to reduce recovery time. What did you find in that study?
I think that we are focusing on getting people back to sport faster and sooner. But the challenge with that is you're balancing that against reliability and the safety of getting someone back earlier and avoiding re-injury. And that has been the subject of, instead of reconstructing ACLs, actually repairing them. But the cost is, I believe, if we change paradigms, we have to make sure we study it and don't lead to a situation where we're actually exposing patients to an increased re-tear rate, which is one of the things that has happened with ACL repair, in my opinion, because it's been extended to patients who would have been better off with a full reconstruction. We are not only as interested in shortening the duration of getting people back to play, but actually reducing the incidence of re-injury once they do get back to play, even if it's the same timeline. So we completed a study with my collaborators in the section of sports medicine at Rush University Medical Center with looking at bone marrow aspirate, where we concentrate bone marrow aspirations, taking bone marrow, concentrating it, and then injecting it around the ACL graft and then into the joint after the surgery. We showed at 3 months that the maturation of the graft was better, and we showed at 9 months that clinically they actually did better than those who did not get bone marrow concentrate. Now, some of those things we're still trying to understand why they happen, but we're still really focused on ways to shorten the duration and improve the velocity of recovery. But even if the graft looks better, you have to go back to why people tear their ACLs, for example, to begin with. And if you don't correct the biomechanical insufficiency, that's why girls tear their ACLs more commonly than boys. If you don't correct the biomechanics that led to the injury in the first place, all the focus on the graft has no relevance. So getting an athlete back to play sooner without correcting the biomechanical deficiencies that led to their ACL injury to begin with. For example, girls jump and land with different flexion angles at their hip and knee, landing on their toes versus their heels. All of that may weigh in, and that has nothing to do with the biology of the graft potentially. That has to do with neuromuscular patterns that they can correct separate from having an ACL or not having an ACL. Having very strong quads with weak hamstrings has been shown to lead to a higher incidence of ACL injury and also a higher incidence of re-injury. So if we don't focus on the stuff that's everyday important, we run the risk of looking at biology in a way that probably takes on too much precedence relative to the risk of re-injury.
So in the late 1980s, cultured chondrocytes implanted beneath a periosteal patch were used as a treatment for chondral injuries, and some animal studies demonstrated hyaline-like repair along with encouraging early clinical results. This led to widespread use and implementation of autologous chondrocyte implantation, or ACI, in the U.S. and Europe. Many clinical studies supported the long-term efficacy and durability of ACI. Today, however, scientists are investigating alternative methods of enhancing the biologic repair and surgical technique using ACI. And you investigated this with some co-authors and recently published a paper in Sports Medicine Reports reviewing this topic. Can you talk about this paper, which was titled Current Status of Autologous Chondrocyte Implantation?
So our study looking at the current status of autologous chondrocyte implantation, or ACI, now we call it MACI because the technology has evolved considerably. Early on, we would harvest periosteum, which is a soft tissue covering of bone. We would sew it as a membrane over a cartilage defect. We would inject cultured chondrocytes from a laboratory beneath that, and patients would reform cartilage or hyaline-like tissue. That procedure has evolved over time. We were one of the first to use collagen 1,3 membrane to actually soak it with the cells and lay that into the defect. And then Vericel, who went through a number of sort of name changes, but the company now, Vericel, has a technology where the cells themselves are actually cultured on a membrane, and the membrane is simply laid within the defect. So we've learned over the years who's a great candidate, who will respond favorably, and understanding the comorbidities that are associated with cartilage defects. It's not just the cartilage defect that leads to the problem. It's the fact that many of these patients have, for example, lost their meniscus, and they've subsequently developed something called secondary arthritis. It's the fact that they've had an ACL tear that led to instability, that led to increased forces across the joint, that has subsequently led to localized arthritis. It's the fact that they're malaligned, they're bow-legged or knock-kneed or varus or valgus, that has overloaded. Again, goes back to that basic concept of load. So the blending of concepts that are both biomechanics and biological has led us to the consideration of how we actually optimize the patient selection to do something like an autologous chondrocyte implantation or the MACI procedure, which is still a mainstay for what we do for certain types of cartilage defects. But what's evolved is that we now have an algorithm that the benefit of doing research, outcomes research, which is the next step after doing either animal or in vivo studies. So you start out in vitro, we then do it in vivo, and then we do it clinically. The advantage is that you get this translational component, this bench to bedside component, that you can take the culmination of basic science, animal work, and then clinical outcomes and say, what is the best decision we can make when the patient walks in the office? And that's the evolution that we've seen with ACI or now MACI.
Could you talk about meniscal tears, which are the most common pathology of the knee and one of the most common pathologies in sports medicine? You co-authored an editorial in the Journal of Arthroscopic and Related Surgery that pointed out that perhaps the most important first step in treating is determining whether the injury is an acute traumatic tear or a degenerative tear. Could you elaborate on this just a little bit?
Well, people who have acute traumatic tears are different of the meniscus are different patients than those that have degenerative tears. So we'll go back to this concept of atul gawande. We're all sort of rotting from the inside out. So as we age, for example, meniscus, collagen, and water content will biochemically change and the tissue will break down. And it usually happens in concert with what's happening to the articular cartilage. That's a different patient than someone who is rounding second base going to third, who then gets a locked knee. The meniscus displaces and just tears from the periphery. That patient, while there may be a diathesis or predisposing degenerative condition, is someone who has a traumatic tear that changes the course of their knee. And the response to treatment is very different. For example, those who get ACL tears with ACL tears, who get meniscal tears, behave differently than those who get degenerative tears. And thus their response to treatments are very different. So differentiating age, degenerative versus acute traumatic, where the normal tissue is simply just overwhelmed and leads to a tear, that's probably more common in someone who tears their ACL and has a meniscus tear, versus a young person who gets a meniscus tear without an ACL tear. Those are different patient populations. So in order to best treat people, we have to understand the natural history of disease and how age and tissue quality weighs into why the disease entity presented in the first place. So you almost have three buckets. You have someone, for when you're talking about the meniscus, you have someone who has a normal healthy knee that has a high level trauma that tears their meniscus. That's actually not as common as you think. Then you have a person who has a trauma that tears their meniscus, and they didn't have a normal knee to begin with, but there was some level of intrinsic degeneration that predisposed them or had a diathesis to tear the meniscus. And then you have a patient who just ages accordingly, and as we age, our tissues change and they get a degenerative meniscal tear. And those three groups all respond differently to treatment and all have a different natural history of their disease, despite being a singular tissue that we focus on, which is the meniscus.
The ability to use bone marrow aspirate or platelet-rich plasma as a source for growth factors in progenitor cells in the area of rotator cuff repair is an exciting development. I understand that you have a paper coming out soon. I am not sure if you want to talk about it, but you have a paper coming out soon that reports on this and highlights reductions in re-tear rates among people with rotator cuff tears. Can you talk about this a little?
Yes. So rotator cuff pathology, like a lot of things, is also a degenerative or attritional disease. Just like we talk about in the meniscus, which can have acute trauma and tear and lead to a rotator cuff tear, rotator cuff re-tears happen despite our ability now technically to do an arthroscopic procedure, a minimally invasive procedure to repair the tendon. Re-tears happen upwards of even 90% from literature from years ago. Now, we've reduced those re-tear rates by improving our ability to biomechanically restore the anatomy by literally improving the footprint by putting the tendon back down to bone. We are shocked sometimes that a year later we do an MRI and they have a re-tear or a failure to heal. So many of us are interested in sort of tricking our bodies to upregulate the body in a way that can lead to a reduction in re-tears. So you have to change the intrinsic properties of the tendon bone construct to do that. So a simple way is to look at orthobiologics, in this case, bone marrow aspirate, which has a number of cells that have cell receptor positivity that would, if you put them in a test tube, behave like stem cells, but it also has often elevation in platelets. So these cells can recruit other cells into the area, so they can recruit pluripotential cells from our bodies into the area and improve healing and change biology. They can produce growth factors locally to potentially make that change. But what we and a couple of others have shown now, and this is the subject of this paper, is that when these are added at the time of surgery, it can change the MRI appearance at 1 year, even potentially reduce the re-tear rate at 1 year. So we're looking for ways to trick our bodies, as I said, in an economically responsible fashion to prevent the recurrence of a tear. And that's just common. Re-tears will happen. The reason we tore in the first place is because the tissue quality was not normal. So we shouldn't be surprised that if we don't do anything to change the natural history other than just put it back down the bone and hope that it stays there, we may get the same outcome 1 year later with a re-tear. And we know that patient satisfaction in a setting of a re-tear is not as high as it is in the setting where the tear integrity remains intact.
So let's talk a little bit about some of your research in biomechanics studies. You've looked at fixation of soft tissue to bone and also fixation of soft tissue using sutures. You and your colleagues have looked at anchors, suture anchors, and other things that you drill into bone to hold sutures in place and grab onto tissue. I understand you've had baseball players with lat tears, pec tears, or you've had to analyze the potential for failure based upon how you do those repairs. Can you give listeners a sense of why this work is important?
One of the greatest things about orthopedics is that it has a whole litany of opportunities to use basic science and biomechanics as a template for how we make decisions. And, orthopedics is really like biologic carpentry in some respects. So we do things, we strive to do things in a less invasive fashion and in a way that's more reliable. So simple things like how the suture interfaces with a tendon to prevent it from pulling free, how an anchor gets put in bone and stays there after cyclic loading. Bioengineering is a really important aspect of what orthopedics is all about. And so therefore it's important to continue to evolve and innovate and to improve, time zero constructs. So we've learned, for example, with latissimus repairs and pectoralis major tendon repairs that, okay, so the anchor, we got to develop an anchor that you can actually put in cortical bone and hard bone. You can't just use any anchor. You have to have one that actually you can put in without stripping the anchor or causing damage. So that seems simple, but that was a bioengineering feat to work with industry to say what's going to work
best to actually drill a hole and put the anchor in place.
The second aspect is now that the anchor is there and the anchor has sutures threaded through it, what should the construct look like when you place the sutures through the tendon so that if the tendon isn't normal, it just doesn't rip apart while the body's trying to heal it with this race against time to get the bone to heal into the tendon or vice versa. So the biomechanics study of surgical constructs is
really important because it
factors into how we actually do things in the operating room to give our patients the best chance for success. And that's been a subject of study with a lot of things that we do.
Brian, as you know, current research on OA and treatment considerations for OA are moving beyond the disease joint, integrating other articular tissues as well as periarticular tissues and structures, muscles, tendons, ligaments, and so forth, in sort of this multi-tissue collaborative. How does this model affect treatment plans?
When we make decisions on how to fix something, it's not just the biology, the biomechanics, but there's sort of an economic and practical aspect of what we do. So right now we don't have the ability to culture cells and use the result of that culture process and use it at the time of surgery because of the regulatory pathway and so forth. So we're always looking for ways to jumpstep the process where we can use tissue that doesn't fall into the regulatory pathway that would otherwise require the equivalent of a drug trial, but at the same time offer biologic benefit. So an example of that is the use of autologous tissue, which has bioactive, biochemical advantages that we really can avoid high-level clinical trial, but at the same time, do something that's economically responsible. So drilling that down, using autologous tissue, for example, minced cartilage. So historically, there was a technique called microfracture where patients would have a cartilage defect. We would poke holes in the bone, and then they would develop fibrocartilage, which is not the same thing as hyaline cartilage. That has evolved over time to say, hey, maybe using an awl and a mallet to cause a hole could be replaced by drilling so that there's less damage, less of a fracture response, but you can still get access to endogenous progenitor cells or maybe MSCs within the patient, mesenchymal stem cells. So then that's evolved to what can we do as an adjunct? And we've learned that if you take minced cartilage, meaning particular cartilage taken from the patient and putting it within the defect, they can form better fibrocartilage repair than they would do without it. So this concept of using autogenous tissue that comes from the patient, is an evolving tenet that involves, for example, we're using bursa from the shoulder, taking it at the time of rotator cuff repair and reprocessing it in the operating room and injecting it back in. There may be bioactive components of that could offer an uptick in the healing response. ACL tissue has progenitor cells that if processed in a minimally manipulated way, which is how we skirt the not in a responsible way, we were able to stay out of the regulatory pathway that treats it like a drug, because we're just using tissue that we would otherwise discard. We can harness the biologic ability of tissue to do something good when we've previously just ignored it. So I sort of call it the buffalo concept. The Native American Indians, would use the buffalo for everything, right? Every part of the buffalo would have some purpose. we have a lot of things in surgery where we harness tissue and we just throw it away because we're just getting it out of the way so we can accomplish the surgical procedure. Now we're trying to look at economically responsible ways that are time efficient, cost efficient, but actually can make a difference rather than these very sort of elaborate techniques that involve soft tissue culturing and so forth, which, I've been in practice 25 plus years, and the only cell-based technology that we use is ACI. I don't have a single cell-based technology in over 25 years that has gone from the lab to the clinic. So we have to look at ways that are, again, economically responsible, that can actually do something productive for the patient to provide some biologic stimuli that doesn't involve going through a drug trial, taking 20 to 30 years and, $50 to $60 million to get there.
Yeah, and until fairly recently, the impact of inflammation on OA pathogenesis was perhaps underappreciated. OA was really not considered an inflammatory disease for quite some time. The field seems to have shifted in its thinking, including effects of inflammation in the periarticular tissues, so tissues outside of the synovial space. What are your thoughts about this?
This is a really critical area of study, and we are getting away from thinking about just what it appears to the naked eye, just cartilage loss, and thinking about the joint as an organ and the effects of the body on that organ. So the inflammatory process starts outside the joint, outside of the diarthrodeal joint that's covered by synovium, but there is a intrinsic relationship as it relates to the synovium, healthy synovium, abnormal synovium, healthy cartilage, abnormal cartilage, that is directly related to the inflammatory process. So our work with my colleague Adam Yankee has focused on the use of biomarkers to say, how do biomarkers as a surrogate for inflammation change, and what is the correlation with clinical outcome? So again, one of the things that we're very careful about is we're not just looking at what happens in a mouse and saying, well, what do you do to a mouse joint and have an impact? You hit it with a mallet, you do something, you hit it with some agent that causes a cartilage breakdown, but it's actually saying, look, we have increased resolution in terms of the tools that we have to study things. But the more sensitive and specific that gets, sometimes there's an increased disconnect to what happens from a clinical perspective. So the focus in our lab is to say, look, we can measure these things now. I can have a patient in the office, put a needle in their joint, pull their synovial fluid off, and look for biomarkers. We can then do a treatment and then follow that patient prospectively and do that same aspiration again to see what changes from a biochemical point of view and with biomarkers. But now we have to correlate with clinical outcome. So doing science just for the sake of science it's great and it provides a foundation, and someone has to do this along the way. But my focus has been on a little bit more on the here and now to say, let's blend the in vitro work with some in vivo study. And then, oh, by the way, there's a patient in the balance. Let's see how that correlates. All these independent variables. How do we do some type of multivariate regression that leads to a clear association with what's happening biochemically and what's happening clinically and what the patients say and tell us? And that's been a very significant focus on the inflammatory pathway, and even getting down to the level of gene editing, where there's an interest in sort of modifying the inflammatory process by looking at gene editing to say, how can we change the inflammatory profile? Because it's so much more than what we see to the naked eye.
So just want to expand on something you said there. Do you envision sort of monitoring the inflammatory burden in synovial fluid or in potentially periarticular structures as a useful means of tracking progression and potentially tracking treatment efficacy?
Yes, because there are preclinical things that happen due to the inflammatory process. But I would say the most exciting area is leveraging the findings of the inflammatory process for therapeutics. So if we understand how the inflammatory process relates to clinical progress, and then we have therapeutic means to change the inflammatory process, to me, that's the holy grail. We really live in a reactionary culture. We're treating disease after it's happened, and we're barely keeping pace with what's happening until the end of the patient's healthful life. So we're just okay in what we do. We're getting by. But if we can actually inhibit the inflammatory process with therapeutics, maybe we can modify disease and prevent it from happening altogether. So the cascade starts with an ACL injury and there's a bleed in the joint. And people say, well, the ACL is torn in MRI, just fix the ACL, the patient's going to be fine. But the toxicity of the hemarthrosis, the collection of blood in the joint, and the macro trauma from a biomechanical point of view has set the stage. So if we can do something that is considered intervention in a biologic way on the inflammatory side, maybe we can actually prevent that patient from presenting in my office 10 years later with osteoarthritis. So that's the most exciting aspect in my mind. It's not just the material and methods involved with tracking. It's the fact that we take known biotherapeutics or unknown biotherapeutics and change the natural course of disease. Like if you really want to make an impact on people and population health, that's really what our focus, in my mind, should be.
As we discussed briefly earlier, stem cell treatments of various kinds are a really potentially exciting development, and there's lots of different approaches to that. And wonder if you could elaborate on this a little bit.
I think that we have to, parse out fact from fiction as it relates to orthopedics and the use of stem cells. Stem cells and progenitor cells and multipotent cells have proven to be very, very helpful in the area of oncology and hematology. When it comes to orthopedics, when you're not culturing cells and driving them down a lineage or setting the stage for them to be driven down a lineage, we're using preparations that might have stem cells in them, but don't necessarily behave in the way that people imagine. So unfortunately, public perception has been the billboard on the side of the road where it shows an x-ray with bone-on-bone arthritis. And after they've had, quote, regenerative therapy, they see that the joint space has been recreated. You can just fly on American Airlines and pick up the airline's magazine and see the same thing. And the challenge here is fact from fiction. The way that we've harnessed, biologics right now that may indeed have stem cells as part of the preparation is not necessarily on the ability to drive those cells down to have repair tissue or regenerate tissue that's been diseased, but rather harness the biologic ability to provide growth factors and upregulate the environment to promote a healing response. So it's a little bit different and it's nuanced, but it's important because, unfortunately, this is driven by the consumer more than it is sometimes the scientist because of misperception. But all that being said, we have truly regenerative therapies that are based upon cellular differentiation that can regenerate cartilage. So we were involved in an amazing study from Korea looking at umbilical cord blood that is cultured from a donor, so allogeneic umbilical cord blood at the time of cartilage repair, where we drill holes in the bone, clean up the defect, use a mixture with a scaffold, put it in the defect to regenerate tissue, has led to symptom relief, and even in patients who have something you might call arthritis. So that's truly using pluripotent cells to drive a regenerative process. That's the kind of stuff that I think we'll be seeing. But again, we have to do things in parallel because that's a 5, 10-year, 15-year prospect, tens of millions of dollars to get there when I have patients today that need help. So it's the blend of what might or could be around the corner with harnessing the biologic ability of these things to help us today in terms of providing growth factors and upregulating our body's intrinsic desire to heal.
You mentioned cultured stem cells, and thousands of Americans travel overseas for this treatment. Are there studies that show increased efficacy in any of those methods?
Some of the best studies have been in induced pluripotent stem cells taken from a hematopoietic system or bone marrow and even adipose. And those studies look very promising. But I don't know, we have issues with safety. We have issues with lack of regulation. For all the criticism that the FDA has, their main function is to protect the safety and provide solutions that might actually have efficacy. And absent of that, it does worry me with what's happening abroad. That being said, it has provided opportunities for us to do things that we didn't have in the United States. So responsible science that's looking at pluripotent stem cells that are induced, often from the hematopoietic system, has actually shown to be very promising in terms of tissue regeneration. So it's an area that we have intrinsic interest in, but we have to be mindful that that doesn't provide the opportunity to be any less responsible as we utilize the opportunity to do things outside the U.S. that we can't do in the United States due to regulatory concerns.
Another specialty of yours is treatment of glenhumeral arthritis, which is a degenerative joint disease affecting the shoulder, of course. It is characterized by degeneration or the wearing away of protective cartilage covering the ends of the bones in the joint. As the articular cartilage degenerates, the bone rubs bone on bone, causing inflammation and pain. So how do you treat a degenerative joint disease like this, particularly in the shoulder?
The shoulder in some ways is no different than any other joint, except for the fact that the shoulder has a lot more degrees of freedom than other joints. And what's fascinating in the shoulder is that people present in the office with advanced arthritic disease by x-ray, having lived with that disease for decades or more, not knowing that it's caused problems or that it hasn't caused a problem until more recently. So they tend to have more advanced radiographic appearances than other joints when they present clinically because people seem to tolerate shoulder arthritis much more. So one of the best operations I do, this is where orthopedics and technology meets biology. Probably one of the best operations I do is a shoulder replacement in terms of reducing or eliminating pain. The challenge is that there's a shelf life for metal and plastic, so we're always trying to figure out ways to take younger people to avoid the need for metal and plastic, and that's the same thing we've done in the knee. In the shoulder, with limited arthritic change, we've been very successful with very simple things like debridement and releasing the capsule and removing bone spurs. That can buy people time, that can build a bridge, that can make a patient more age appropriate for a shoulder replacement. We do cartilage transplants now in the shoulder where we do donor cartilage and bone to restore bone loss on the glenoid, the cup, the golf tee, if you will. We do bone and cartilage restoration in the humerus for people who have avascular necrosis, where they've lost localized areas or they have local cartilage defects. The thing that's different about the shoulder is that the epidemiology, the incidence of these problems with limited disease where they actually present in the office is far less frequent than we see in the knee or the hip or other joints. And it's not, and I don't exactly know why people say, well, it's not a load-bearing joint. The shoulder is a load-bearing joint, but I think the way it gets loaded and the redundancy in the system may lead patients to present later, and they present with more advanced disease. But if we get a person who actually has a symptomatic localized cartilage loss in the glenohumeral joint before they get to be end stage, we can do the same treatments in the shoulder that we do in the knee or other joints.
You talked a lot about approaches prior to full-blown, shoulder replacement. Give us an idea of sort of what is the lifespan with current technology. What's the lifespan of a current shoulder replacement?
We used to cite glenoid component failure in the neighborhood of about 25% after 10 years, maybe 12 years, something in that neighborhood. But I've been doing shoulder replacements for 25 years, and I think if you look at modern apples-to-apples comparisons, we're doing much better than that. So the humeral component seems to be doing much better. We have less invasive implants now that are surface replacements, if you will, not long stems and things like that. So should they fail, much easier to revise. But the glenoid side is the one that was always the worry for our younger patients, and we spent so much time and effort in avoiding placing a glenoid component, which is polyethylene. And that's a cement polyethylene implant. And biomechanically, that's what is probably the most vulnerable. When you have tissue ingrowth into an implant such as metal, that seems to survive the test of time. And we don't see humeral component failure, which is a metal implant, very frequently. What we do see failure on is the glenoid side. And in my opinion, every attempt to avoid putting a glenoid in has led to a less good clinical outcome compared to those patients who actually have a glenoid implant. We've done less well with metal implants where you have bone ingrowth in the metal than we have with polyethylene. Again, the problem with polyethylene is that it's a hybrid of being press fit without bony ingrowth and cement. And cement, has a finite life, and that's the big challenge. So all that being said, glenoid implant design has evolved over time where I think we're seeing greater longevity. So when patients ask me that, I say, look, the literature has often taught us that we see glenoid implant loosening and wear over time, and somewhere in the 10 to 15 year range, you may represent. Point in fact, being in practice 25 plus years, I will tell you that the number of patients who have come in with failed glenoid components is very, very small. So we have a lot of implants out there that are surviving more than 20 years. So I think we're doing very well, better than we used to do, probably because advances in biomaterials, advances in implant design, and our understanding of how the surgical procedure gets performed.
How does reverse shoulder fare compared to anatomical shoulder replacement?
When I look at the techniques that have changed the course of care and had enormous impacts on our patients, I would say reverse shoulder replacement is one of those. Reverse shoulder replacement is a procedure that basically has replaced other techniques in patients who have no rotator cuff, who develop a condition known as rotator cuff arthropathy, which is where there's biomechanical imbalance around the shoulder because there's no functioning rotator cuff and they get secondary arthritis. Those patients did not well when we did shoulder replacements. They led to instability, no pain relief, and basically clinical failure. The reverse replacement, where the ball, if you will, is placed on the socket and the socket is placed on the humeral side, is a biomechanical operation that obviates the need to have a functioning rotator cuff and provides a stable joint replacement that leads to pain relief and functional return probably more reliably than any other procedure I do in the body. And if I think of what's been evolutionary, and I would even call it revolutionary, because I wasn't doing reverse replacements when I was a resident early in practice, that has been the most dramatic impact on patient outcomes, is a solution that is surgical in nature that can change the life of an individual, that has the most marginal gain in terms of how they in-go. In other words, when they present to the office, their in-go in terms of how they feel versus their out-go in terms of the surgical outcome. There is no more dramatic impact in patient wellness than a reverse shoulder replacement for a problem we virtually had no solution for.
The British Medical Journal published a study back in 2019 that reported the risks associated with shoulder replacement surgery for arthritic conditions is much higher than was previously thought in some circles. The study found that 1 in 4 men aged 55 to 59 were at risk of needing further revision surgery, and they continued that there was risk of serious adverse effects like heart attacks and substantial blood clots within 90 days of surgery were higher than had previously been estimated, particularly in this case in people over 85 years old. What are your thoughts about this study, and how should we understand the results and interpret them?
Well, it's there's this concept of sort of leaning on research and applying it broadly. I think that the details matter. I think the population matters, who's being studied. I think that if it's I don't know if this was an outside U.S. population. So the study you're referring to, I have not read. What I would tell you is that I hear, people will report their outcomes, and I will tell you that has not been our experience in the United States. We have identified obesity as being a significant comorbidity in shoulder replacement surgery at our institution. That being said, the ability to get a good or excellent result with minimal physiologic comorbidities is still the mainstay. And to say that it's 1 in 4 in the United States in a center where you have experience, I think it's the experience that you get.
Yeah.
That would be a gross overestimate. That is not our experience to date. And in fact, the complication rate for reverse arthroplasty, which cited the highest complications, has gone down to, in my opinion, less than 5% with changes in implant design. So I think you have to look at the time period that was studied, the health system that is studied within, and frankly, the surgeons who are reporting those results. All of that has to be taken into consideration. There is a learning curve. There's a programmatic aspect to doing the surgical procedures. There's the perioperative considerations in managing the wellness of a patient that have to be taken into consideration. So to broadly apply to say that 1 in 4 have a significant complications would be a gross overestimate to what happens in clinical reality in the United States. And specifically, I would tell you with amongst my colleagues who are trained to do this procedure, who have a strong clinical experience doing it.
Brian, that study, as you may know, is often cited in convincing patients to pursue other non-surgical treatments, such as stem cell. So that's one of the primary studies that is given to patients to give them confidence in avoiding shoulder replacement. And I think that's where it's had a substantial effect, actually.
Yeah. I think the way to think about it is, look, no surgery is a good surgery, and avoiding surgery is fine. And that's that concept of skillful neglect. So the fear of when you decide to transition from non-surgical to surgical, you have to say, look, have I exhausted all non-surgical options? Is the surgical procedure likely to deliver what I'm looking for in the absence of anything else, in the absence of the natural history of the disease that would otherwise lead to resolution? And can it be done so with minimum complication rate and downside and a high likelihood of success? I would argue that when a patient is out of options, real options, not fictitious options where stem cells are purported to regrow cartilage and change the natural history of the joint, but real options, when those fail to modify symptoms, I would argue that that study using to say, well, just don't do surgery because it won't work or there's a high complication rate, I would say is not a proper interpretation of that research. That being said, people are led to choose desperate means, even in the lack of evidence. My feeling is that, look, even meaningless scientific solutions can have a placebo effect. And frankly, most of what we do probably has up to a 30 to 35% placebo impact. In fact, my treatment, me talking to a patient, has a placebo impact on a patient. And there's nothing wrong with placebo impact, in my opinion, right? So
no side effects.
Yeah, there's no side effects.
Right.
And it can be free. And it can be free. So there's an enormous complexity in what you asked. I would argue that it should not lead people down a rosy path of wishful thinking, spending thousands of dollars, potentially putting them at risk for infection and other even worse complications because they're fearful of something that is otherwise probably more reliable in the end. So it's a philosophical discussion as much as it is a scientific one.
Agreed.
In addition to your medical practice, you are also in the podcast business. You host a weekly show called Sports Medicine Weekly Podcast with Dr. Brian Cole. Can you talk about the range of topics you cover?
The genesis of the podcast was to provide an opportunity to reach the public, much like you do, who has interest in their health. So we cover everything from, injury prevention, youth sports, nutrition, the psychology of sports, the management side of sports medicine, on-the-field management, concussions, supplements, regenerative technologies, biologic therapies. Honestly, all the things that you and I discussed today can be the subject of a podcast in a more specific way that provides sound bites that are digestible and understandable. And, my listenership is the everyday individual who is looking for good, authentic, validated information that's scientifically based, but presented in a way that they can understand it. And I think that, the desire for me to do a podcast was predicated on, I feel like I do a good job in the office, one patient at a time, but I really was desirous of having a greater impact. And while you can write a book, people have such attention deficit now, their ability to sit down and read a book on a single topic, and the efficiency of it, even in an audiobook, is not nearly as good as having a 15-minute soundbite that people can listen to provide good information. And that's the subject of Sports Medicine Weekly.
Thank you. That sounds really cool. I'll have to tune into that.
I have listened to it. It's pretty broad and pretty interesting.
Cool. Brian, this has been great fun. I know you're a busy guy. Thanks for taking the time to talk to us today.
Thank you for having me. It's been an honor and it's been a pleasure.
Yes, you were excellent, Brian. Thank you very much.
STEM Talk. STEM Talk. STEM Talk. STEM Talk.
This is an interesting time in terms of sports medicine because we now are seeing more non-surgical as well as minimally invasive surgical options for knee, hip, and shoulder injuries. But to me, the most exciting development on the horizon is the use of potentially stem cell and bone marrow treatments and the work that Brian and his colleagues are doing in these areas.
Yes, these are indeed exciting developments, and they may revolutionize orthopedic medicine. I also like Brian's approach to medicine, which is to treat the patient rather than the X-ray or the MRI. You don't hear a lot of surgeons say, "I'm a physician first." I really applaud that about him.
If you enjoyed this interview as much as Ken and I did, we invite you to visit the STEM Talk webpage, where you can find the show notes for this and other episodes at stemtalk.us. This is Marcus Baumann signing off for now.
And this is Ken Ford saying goodbye until we meet again on STEM Talk.
Thank you for listening to STEM Talk. We want this podcast to be discovered by others, so please take a minute to go to iTunes to rate the podcast and perhaps even write a review. More information about this and other episodes can be found at our website, stemtalk.us. There, you can also find more information about the guests we interview.